Good morning. I am Dr. Sunantha, reader from the Department of Prosthodontics and Crown and Bridge. I am working in Vinayaka Mission Shankaracharya Dental College, Salem. My topic on voiceover presentation is on vertical jaw relation. So, this presentation briefs on the significance of vertical jaw relation, the methodology that we have to carry out in the clinical procedures, and the effects of varied jaw relation. So, let's move on to the presentation. During the treatment of a completely edentulous patient, jaw relation is a vital step. The complete denture should be in a good adaptation. The patient should have a good masticatory system. They should have a optimal contacts between the teeth, and they should have a harmony in their temporomandibular joint and the muscles of mastication. Maxillomandibular relationship, according to Glossary of Prosthodontic Terminology 8, is a spatial relationship of the maxilla to the mandible and any one of the infinite relationship of the mandible to the maxilla. Jaw relations can be classified as orientation jaw relation, vertical jaw relation, and horizontal jaw relation. This presentation is on vertical jaw relation. Vertical jaw relation can be classified as vertical dimension at rest, that is VDR, and vertical dimension at occlusion, that is VDO. Vertical dimension, according to GPT 8, it is a distance between the two selected anatomical points. One in the tip of the nose, that's a fixed point, and the other one is in the chin, that is a movable point. The single most important factor in deciding the vertical dimension is the mandibular musculature and the occlusal stops, that is the teeth. Physiological rest position is an important criteria to determine during the vertical dimension at occlusion and rest. So according to GPT-8, it is a position where the patient's head is in an upright position and all the muscles of mastication are in equilibrium and in tonic contraction, and the condyles are in a neutral unstrained position. The patient's posture is the most comfortable posture for the patient, and the repeatable posture. Significance of the physiological rest positions are the patient's bone to bone relationship are perfect. It is a constant position throughout the life of the patient during mastication, so the patient doesn't develop any kind of pathogenesis, and it is a recordable, measurable, and reproducible position within the acceptable limits, and it is used to determine the vertical dimension at occlusion. Vertical dimension at rest is defined as the distance between the two selected points when the mandible is in the physiological rest position. Vertical dimension at occlusion, according to GPT-8, is a distance between the two points when the teeth are in contact. In case of jaw relation, when the two occlusal rims are in contact. Once the vertical dimension at rest and the vertical dimension in occlusions are measured, the difference between the two gives the freeway space or the interocclusal rest space. This space is usually 2 to 4 millimeters, and it is preferably measured in the first premolar region. Vertical dimension at rest has the following factors. The patient should be calm, cool, and comfortable. The measurement should be taken without delay. The gravity is a vital role during measurement. If the patient is having a neuromuscular disturbances, the mandible will have a jerky movement, and recording a jaw relation is a task. So there's no one single method to determine the vertical dimension at rest. So we have to follow several methods in order to record it and confirm it. The methods that can be used to record the vertical dimension at rests are mechanical method and physiological method. Mechanical method is an arbitrary method, or it is an average value of the previous edentulous patient or the dentate patient. And the physiological methods is a method where the patient as well as an operator should have a proper cooperation to record the vertical dimension at rest. Let's start with the mechanical method. First comes the ridge relationship. The incisal papilla is a stable landmark in the completely edentulous patient. So the distance between the incisal papilla to the incisal edge of the mandibular anterior teeth should be around 4 mm, and the incisal papilla to the incisal edges of the maxillary central incisor should be 6 mm. So the vertical overlap is about 2 mm. This is otherwise called as overbite. So this might vary from individuals due to severe resorption. The next comes the parallelism of the ridges. When the patient is opening, the posterior parallelism can be up to 5 degree according to shears, but it is highly impossible because the patient might have lost their teeth due to some periodontal diseases, or the patient might have extracted the teeth in different time periods, and because of supra eruptions, always the ridges may not be parallel to each other. Then comes the measurement of the previous denture. If the patient is walking into the clinic with the previous dentures, it is always advisable for an operator to check the previous denture, whether the vertical dimensions are proper, if the face dimension is okay, if the lip support and the perioral tissues are fine, then we can always go ahead with the same vertical dimension. If you find any kind of discrepancies, we have to note down so that we can rectify in our dentures. Pre-extraction records are the records which is more predictable. So if the patient is having the pre-extraction record, it will be very much of use. Or if the patient walking into the clinic and asking for a complete denture, and if your treatment plan is for complete extraction and teeth is present, we can follow few of the methods before we do our extractions. So before the extraction, we can always go for a profile radiograph, that is a lateral skull view, and it is compared with the skull view after extraction. So before and after extraction has to be taken, but the radiographic risks are there. If the patient is having his previous IOPAs or OPGs, even the height of the teeth can be used to determine the height of the face, and also for the teeth selection. Profile photographs can be made when the teeth is in maximum occlusion, and that picture is enlarged to the life size during the measurement of a vertical dimension at rest and occlusion. Profile silhouettes is nothing but a shadow of the photograph. This is enlarged to the life size, and again this can be used to determine the vertical dimension of the patient during rest and occlusion. The lead wire can also be adopted on the outer surface of the shallot, and that lead wire can also be repositioned during the vertical dimension determination. The pre-extraction casts, if present, is always useful to determine the vertical dimension, and the height of the teeth, the size of the teeth can also be determined. According to Swenson, in the year 1959, he made a resin face mask. This resin face mask is done before the extraction, and it is compared with the vertical dimension after the extraction, and it is used for restoring it properly. The main problem is that it is very costly and it is time consuming. Facial measurement before extraction is the most simplest and the ideal method you can follow. So we should record the vertical dimension at rest and occlusion before the teeth is being extracted. Will's gauge is a gauge which is used to determine the length between the corner of the eye to the corner of the mouth, and from the ala of the nose or the base of the nose to the um, lower border of the mandible. So both the distance should be equidistance, and this is a device which is used. The concepts of equal thirds. This is a pretty easy technique. The face is usually divided into equal thirds. One from the headline or the hairline to the glabella, from the glabella to the subnasal, and from the subnasal to the menton or the chin. The upper third, middle third, and lower third should be equidistance. So during the measurement of the vertical dimension at rest, this distance can be helpful to determine our vertical dimension at rest. So once the mechanical methods are been determined, then comes the physiological method. So first is a physiological rest position. So this is a position when the patient is in the most relaxed position. The patient should sit in an upright position. The trunk should be straight and the head should be unsupported. The upper and the lower bite trims are inserted into the patient, and the patient is asked to swallow, and the jaw should be in a relaxed position. When recording, the lips should be apart so that we'll be able to see the space between the two occlusal rims. The space should usually be around 2 to 4 mm, that is the freeway space in the premolar region. Once the maxillary and the mandibular bitrims are inserted in the patient's mouth, the height should be determined. In case of maxillary, depending upon the length of the lip, the bitrim can be up to the level of the lip or just 2 mm below the lip. In the case of mandible, it should be to the level of the tongue or to the corner of the mouth. So if there is discrepancies, we have to adjust accordingly. Once the maxillary bitrims has been inserted, we have to check the nasolabial angle. If it is obtuse, then it says that the upper lip support is not adequate. Here you can see the patient has wrinkles and the lip support is not adequate. It gives more denture-like appearance. So we have to add a layer of wax labially in order to provide a better lip support. Niswanger's method. This is a method which is usually carried out during our clinical procedure. Here, the camphor line or the alatragal line and the interpupillary line are the hallmark in this procedure. The patient should be asked to sit in an upright position so that the occlusal planes are parallel to the floor. The markings are done in the tip of the nose and in the stable area of the chin. A camphor line has been drawn, that is from the ala of the nose to the upper border of the tragus. This line should be parallel to the posterior occlusal plane, and the anterior occlusal plane should be parallel to the interpupillary line, which is an imaginary line. Once the parallelism of the bitrim has been determined, the patient is asked to swallow and be in a relaxed position. Now, the distance between the tip of the nose and the chin point is measured, and this gives the vertical dimension at rest, and the patient is guided to bite in a centric occlusion position, and the dimension is measured, and this is called as the vertical dimension at occlusion. So the difference between the two gives the freeway space, that is around 2 to 4 mm. So that is usually an average of 1/8 of the actual measurement. Phonetics, it is an important characteristic of a complete denture. So when the patient is speaking, it is up to the observer to listen to the sound production and also observe the relationship of the teeth during the speech. While observing the phonetics, the patient is first asked to pronounce the letter M or Emma. Here, the lips comes in contact with each other and the patient is in the most relaxed position. This is called as the bilabial sounds. So the patient is engaged and he is diverted from the regular procedures so that he will be in a relaxed position and the mandible drops and the next measurements are carried out little later. Next comes the syllable sounds. They are S, J, S, H. Here, the anterior teeth come close together. The lower incisor should move forward to a position almost closer or almost it touches the maxillary incisor teeth. Here, this sound is caused when the air passes between the maxillary anterior and the mandibular anterior teeth. If the bite rim hit each other, it causes atypical S sounds. If there is too much of space between the maxillary and mandibular bite rims, it also causes a sizzling sounds. Silverman's closest space is a space when the patient is pronouncing yes, the maxillary and mandibular bite rims comes very close to each other, but it doesn't hit each other. So that space should be a minimum of 2 millimeter. So this space is called as the Silverman's closest space. If the space The next sounds are F and B sounds. These are labiodental sounds. Here, the incisal edges of the maxillary anterior teeth creates a seal on the moist area of the vermilion border of the lower lips. If the height of the maxillary rim is more, it again causes an atypical sound. If there is more gap between the maxillary anterior teeth and the mandibular um, lip, it causes a atypical sound. The next most once the aesthetics has been achieved, we have to check for the facial expressions. In a normally related jaws, the lips will be in a normal anteroposterior position. When there is some problem in the vertical dimension, there might be a retrusion of the mandible or the prognathic mandibles. The skin around the eyes and the chin should be in a relaxed position. The nares should be in a relaxed position, which says that it is in an unobstructed breathing condition. Swallowing threshold technique is a technique where the cones of waxes are built up in the lower denture base. Here, the patient is asked to swallow. So, during the beginning of swallowing, there is a very slight contact of the cones to the maxillary bite rims. So there will be a high point of contact during the completion of swallowing. So that position is called as the vertical dimension at occlusion. So that position can be recorded. And this method of swallowing is a repeatable action and that can be used for recording our vertical dimension at occlusion. Then comes the tactile sensation. The patient is instructed to sit erect and ask the patient to open the jaw wide and feel whether the muscles are being strained or whether it is in a relaxed position. If the patient is comfortable in opening and closing of the mouth and if the skins are all in an unstretched manner, then this position is a most reliable position. We have now discussed the different techniques that is used to record the vertical dimension at rest and occlusion. We should also record the vertical dimension during the trial stage in the patient's mouth. We should see whether the patient is opening and closing in a proper way, whether there's a proper teeth contact, and there is any discomfort, and the tactile sensation of the patient is also seen. The phonetics of the patient is verified, ask the patient to say 33 and in 30s. If there is enough space between the tip of the tongue to protrude between the anteriors, it is fine. The patient is asked to say 55. Here, the incisal edge of the maxillary central incisor should contact the vermilion border of the lower lip. Again, this will help to determine the height. And ask the patient to say the words which starts with M. Here, the teeth shouldn't contact. So all these are again rechecked during the trial stage. If any problem exists, after evaluation of vertical dimension, if we go wrong in determining the vertical dimension, these are the effects of increased vertical dimension. The patient will be discomfortable. There will be pain and trauma in the basal seat of the denture, which eventually causes ulceration in the mucosa. There will be loss of freeway space, and the patient will always complain of a clicking sound because of premature contact of the teeth. The lower face will be elongated and the lips will be obliterated, and the patient will try to overclose the lips, and it gives a strained appearance. Uh, there is a loss of retention and stability in their dentures, and because of constant pressure and premature contact of the teeth, it causes a generalized hyperemia on the basal seat area. So this causes a bone loss. The decreased vertical relation can be tolerated to certain extent by the patient. There is always an inefficiency for the teeth to have a proper contact. So this will result in overclosure, and there will be an increased muscle strain for the patient. There will always be a cheek, tongue and lip bite because of reduced vertical dimension. The appearance of the face will look like a denture look, or otherwise called as a witch look, and there'll be a sagging of soft tissues. There'll be lines and wrinkles in the perioral areas. The facial expressions will also be changed. Angular cheilitis is the most common symptom of a decreased vertical dimension. This is seen in the vermilion border of the lips. Here, the saliva gets accumulated on the folds, and this leads to infection and soreness on the foldings. The patients will also complain of temporomandibular joint pain because of overclosure. Costin syndrome is a syndrome which is also caused due to decreased vertical dimension. Here, the tongue has a tendency to move towards the throat. This causes an obliteration of the eustachian tube, and this interferes with the function of the ear. This causes titinous or napping sound in the joint, tenderness in the temporomandibular joint. It causes dryness of the mouth, and it causes a neurological disturbances or some burning or pickling sensation in the tongue. As we have seen the effects of decreased and increased vertical dimension, it is our duty to look after our geriatric patient who has to be rehabilitated with a complete denture. So there is no single method to determine the vertical dimension, and we have to have repeated and many methods has to be used to assess the vertical dimension at occlusion and rest for an edentulous patient. My references are from the most of them are from the books of Thank you for the patient listening.